thank you, everybody, for joining this next webinar in our series with UM6SS. Today, Stephanie from the Health Systems Collaborative will be presenting about some of her work on the experiences of professional values from some work in Kenya. So we'll record this as usual. If you have any questions, please put them in the chat, and there'll be time at the end for question and discussion. So over to you, Stephanie.
Thank you, Catherine. Thanks for inviting me. Just to give a little bit about myself, my name is Stephanie Nzekwu. I am currently a postdoc at HSC. I'm working as a coordinator under the Roots program, and I'll tell you more about Roots as we go on. I got my PhD from Warwick Business School, where I studied frontline professionals, particularly medical professionals in Kenya. And my research interests lies in professions, professional identity, organizational behavior, emotions, and research in healthcare systems in the global south. So I'm just going to dive into my work now. This particular presentation involves two studies that are interconnected, and you will see how they are linked. But the overarching title is Frontline Professionals Working in Resource-Constrained Health Systems. So I'm just going to go on with, let's see. Okay, it's not working. Right. So to start with, that's the title for this particular study. This one is on experiences of professional values violation among novice physicians in the Kenyan health system. This is linked to my PhD. I want to recognize my co-authors. We're working on a paper with this one. Jeremy McGibbon from King's College, April from Warwick Business School, Jacinta from LSTM, and Yinji and Mike and Daniel from Kemry and Oxford. So just because I'm going to be speaking to you for the next 35 to 40 minutes, I am asking for your attention, and I'm also asking for your feedback and to see if this resonates with any of the research that you're doing. It would be nice to have a chat right after this. So I'm going to start with this quote from one of my interviewees, and it says, "The system has failed so many times. I feel like," and she goes, "What's the need of being in the medical field when I can't help my people?" And this is what a lot of frontline doctors in the system, in the context that I interviewed them, experience. A lot of systems failure. And today we're going to be talking about values violation, and the systems failure can lead to lots of values violation. But before we dive into our findings, let's first of all look at what values are. So we're looking at values within the context of professions. Professionals, we know, are a unique set of people in the occupational ladder. They're very special because they possess expert knowledge. They possess expert knowledge in their field, and they pride themselves in their certification. They also pride themselves in their long-term socialization and training that helps them to inculcate the values that accompanies the profession. Professions are very values-oriented. Values are the conception of what we want to see. They're the desirable things, that the desirable structures that we want to experience. They are in our heads, they're in our hearts. They help us define our purpose. They help us to define our goals. They help us distinguish between what is right and what is wrong. In many institutions, the value serves as a stability mechanism, enabling them to persist over time. Talcott Parsons, one of the early sociologists, talked about values being interwoven in the fabric of professions, and he talked about professions being the future of the world and helping to preserve the good and the morality that we have in society. There are several expectations that we expect professionals, several values expectations that we expect from professionals, including having altruistic values, being dedicated to community service, adhering to the ethics of their profession, not being driven by profit, and so on. affinity with values, or professionals come in contact with values during their training and socialization process. This is how they get to embody what it means to be a professional in this space. So now we've spoken about professions and we've spoken about values. We're now going to talk about professionals on the front lines. And these are a very important group of people that embody the professional behavior. Now we know professional behavior emanates from the Western ideology, and it's been described as an English disease that has gone and spread through other societies. But frontline professionals are the ones that carry these values, they diffuse values, they help interpret what is right and what is wrong in many spaces. So we have several elite professions like the medical profession, the accounting profession, the engineering profession. The frontline professionals are the ones that help to interpret what's going on and how the work, the practice should be carried out in line with the professional code. We see frontline professionals also performing the work as guardians of these values to ensure that these values are enacted in practice. Novice professionals are usually put in front of in practice to ensure that they inculcate the values that are on ground and they learn to embody these values on ground. However, we know that there are surprises that can happen. We know that literature has talked about the reality shock and the disconnect that new professionals can experience when they're in the front line. So they usually experience a discrepancy between theory and practice. This is well expected. However, we see that there are several unmet needs, or there are several unexpected practices that they can experience that can be perceived first as errors, and some can be perceived as violations, giving them that negative feeling in negative experience that something wrong has occurred and it needs to be corrected. So now that we've spoken about frontline professionals, we're going to talk about systemic values violation. And we see that many times, some values from violations can be mistakes, but there are sometimes that values violations might be systemic. These violations are embedded within the institutional structures and processes. And so we define systemic values violations here as violations that are persistent, that are serious, departures from professional value standards, and that are institutionally embedded, which can cause adverse harm to people and organizations. Now, we know that in many Western contexts, literature has documented that the nature and frequency of violations, of values violations in this context has been shown to challenge the moral fabric of what it means to be a professional. Many times professionals question their ideology, their values as a result of the context that they are in. And so now that we've spoken about new professionals, we've talked about values, we've talked about systemic values violation. This research was carried out to understand or to answer the research question: how do new professionals respond to systemic values violations in frontline work? And we collected data from Kenya. Kenya was a very good context because there are several challenges in this context: acute resource constraints, weak institutional infrastructure. The Kenyan healthcare system is plagued with a lot of with shortage of staff, and we just wanted to understand how new novice professionals would respond to these challenges that are bound to produce some form of values violation. So we collected data between the period of 2021 and 2022, and this particular research formed a part of a broader research endeavor to look into how to strengthen the human resource in the Kenyan health system. So this particular study was a qualitative study where we leaned on semi-structured interviews. We collected interviews from 51 aspiring doctors. 18 of them were 3 months away from internship, while 33 of them were either beginning their internship or towards the end of at different stages of their internship, and they were scattered across 11 local counties in Kenya. many of them, or most of them, were practicing or carrying out their internships in public hospitals. We also drew data from field visits, from secondary data sources as well, such as media documents, government reports, and policy manuals, and so on. The analysis for this study was very inductive, but we used the JOYA method, which is just a systematic way of interpreting data and going from first order codes to theoretical building, just to show that the rigor and the transparency in arriving at our findings. There were several discussions that took place during the process to ensure contextual sensitivity and credibility of the findings for this research. So I spoke to my co-authors as well as the wider academic community to arrive at a good interpretation of what my data was trying to say. Because I'm coming from the business school and there was a lot of negative views of what can come out of the African context, I was plagued with the challenge of how to present my data in such a way that it's not just highlighting the negative aspects of working in Africa, which was what we were used to seeing in the business school. Oh, Africa is a dark continent, nothing good can come out of there. But it was quite difficult for me at the time, and this was what I struggled with alongside my co-authors. How do I talk about these negative experiences of systemic values violation, and also how do I, because even though they experienced systemic values violations, these doctors had some wins, they had some positive experiences. I didn't want to ignore those positive experiences, but then there were these negative experiences that they had, and it was all emanating from the systemic failures that violated their values. How do I communicate this to the academic community? And also I was thinking about how do I do this and not ignore the negative accounts in the data, because these people that spoke to me trusted that I would report what they were trying to say, report their distressing experiences, and they would kind of see some kind of solution from what they had spoken to me about. And I really was challenged by that. I went into the literature and I found this paper by Bernard, and Bernard talked about the Africa we want to see and the Africa that we see. And I extracted this statement. She said in her work, to the extent that we theorize the Africa that we see, we help create the Africa we want. This means we need to theorize the Africa that causes us sadness, anger, frustration, and hope. We need to theorize the dysfunction that sadly so often characterizes our context when it occurs. Our task as scholars is to identify what are the mechanisms that result in certain outcomes. And this kind of gave me momentum, that drive to interpret my data inductively, leaning very closely to what the statements I was getting from my interviewees, and trying to build this into a way that will generate some theoretical thinking. And so I used the JOYA structure, and this is just a transparent way of showing how I went from statements of first order concept or codes drawn from the data to my second order themes drawn from the literature, and then eventually to my labels or the aggregate theoretical categories in order to respond to the research question of how new professionals respond to systemic values violation in frontline work. So this is just the structure of the analysis that I conducted during that study. The summary of the finding is, whenever they encountered systemic failure that brought about systemic failure, this brought about an erosion of exposed values that they were taught in medical school. So many of these students, of these doctors I spoke to, were trained according to the Western curriculum. Many of them were trained in level 6 hospitals, which means that they were in relative, we could say that the hospitals where they did their training, their training was relatively well equipped compared to where they were sent off to do their internship. So when many of them got to their internship centers, they realized that they lacked basic supplies such as gloves, bloods. Many times the resource constraint made it impossible for them to carry out proper investigations. Many of them talked about learning witchcraft medicine and, pursuing patient care without any kind of evidence or investigations whatsoever. New doctors also watch patients die painful and potentially preventable deaths, and this for many of them was very traumatic. Also, we discovered from my data, we discovered 3 pathway responses to the systemic values violation. Now you might say, oh, but they know that the system is not right. They know that the Kenyan health system is broken or is failing. But this quote goes on to say, mentally we know that our system does not work. Our systems don't work, but being physically there to witness that the system does not work is not the same thing. You learn to cope because the patient is there and they are looking up to you. And many times they found themselves in this double bind whereby they had to act no matter what, despite the fact that they had some of them had no resources for the desired patient outcome. They still found themselves having to do something in order to help the patient because, like this quote says, the patient was looking up to them. Now, going into the findings, I'm going to be telling you a lot about, the quotes to support some of the work, some of the labels that I identified in this in my data. So this talks about the expected ideals or the expected values that they wanted to see, the expected values surrounding care, competence, professional conduct, and their career. But regarding care, we found the violations, and these violations were worsened by the resource constraints and the practical norms that they engage with in the clinical environment. Now, practical norms are norms that are tolerated, but they are unofficial. They are informal, and they largely, or to a very large extent, deviate from official or professional norms. So they encountered violations surrounding care. So they felt patients were not being considered as important, contrary to what they were taught in school. They felt patients were being treated unfairly. They felt patients were poor, they couldn't afford their treatment, and the resource constraints in the health system made it even worse for patient treatments to be possible, and they felt patients were being treated without investigations. Someone even talked about recognizing the Guillain-Barré syndrome just by looking at the patient and not being able to carry out investigation, but he just had to guess what the patient had, and he actually got that particular condition right. However, they just felt it was wrong for them to care for patients in this way. There was also violations surrounding professional competence. Some of them felt they lacked direct supervision. Many of them were made to start their internship all alone. And some of them engaged with trial and errors that led to preventable deaths and put a lot of patients at risk. Generally, they felt that the work that they were being given to do was above their pay grade as trainees. Then there was the professional values violations surrounding professional conduct. There was a lot of reports about misconduct in the system, about the culture of bullying, about blame game, engagement with practical norms that were transgressive, such as African time, scoring, or should I say taking advantage of patients and their relatives, and absconding or negligence. These were tolerated practical norms that they felt were transgressive in nature. And then there was also the lack of sanctions and even proper channels to report violations when these violations occurred. Then there was the last one, which is expected values that surrounding career. Many of them wanted to be doctors because they felt they could help people for a long time, but there was this uncertainty in the employment environment about being able to care for patients even in the future, and many felt that this was a violation of what they expected to be of a violation of their profession, of their professions as medical doctors. They also felt the working conditions within which doctors were carrying out their practice was very bad, and so they felt doctors were not treated fairly. Now we have a general response from these doctors when they experience these violations. We had a general response of sympathy, of course, for patients, and there was this building up of negative moral emotions of guilt, anger, sadness, disgust towards the system. And many times these interns tried as much as they could to restore what they felt the ideals were, to restore the values of the profession while in the front line of practice. But then the more they tried, the more many of them experienced that blockage again. And when they felt they could not proceed with what they wanted to derive, with the positive outcome they wanted, this triggered even more negative moral emotions, that sense of futility, a sense of powerlessness, that there was nothing they could do against the system. And there were some quotes like that: "You can't beat the system," was scattered all across this data. So we found 3 response pathways to systemic values violation. When we looked at our data, we saw that the interviewees had 3 ways of responding to these systemic values violation. Now, these responses are not mutually exclusive. I would say many of them had a mix-up of these, but most often we saw these pathways very highlighted in all across the data. So for instance, the first pathway was the traumatized departure pathway. And these ones, whenever they experienced violations, they experienced it through their individual selfhood. But this is because they had entangled their individual identity to what it meant to be a professional. So they had deep commitment to the values. So they've connected themselves, being a doctor, being a a physician, to who they were. Their integrity, their personal integrity, was tied to the integrity of the profession. So some of them talked about being a good doctor, saving lives right before joining the practice. One even said she felt she was continuing the ministry of Jesus and continuing Jesus' work. That is who she saw herself as being. And when these ones experience negative systemic values violation, it kind of triggered personal and painful moral emotions. But these moral emotions were seen to motivate them to engage in extraordinary interventions. For instance, they could see a patient who could not afford to pay for their treatment, and they would, take out money from their pocket and pay for the patient's treatment. And also they would try to find ways to overcome blockages. But a lot of times this was not sustainable because the disruption, the blockages were constant. And like I said, they were institutionally embedded. And also it was quite difficult to overcome these blockages. So many times these ones felt overwhelmed, and whenever they couldn't achieve what they wanted, they felt the sense of personal failure. Some of them felt like it ended up running away from the practice environment for a while. Some of them talked about engaging in substance abuse. There was just this feeling of moral injury, which is that feeling that a very core value has been violated, and this can bring about or trigger negative experiences, even a very dark view of life. So the response outcome we labeled as moral injury because we could see symptoms of trauma, symptoms of the sense of being overwhelmed in this system. And these ones also had the need to escape from the systemic failure. For instance, this quote says, "There's only so much that someone can take. I feel like every single time I try to be good, I try to help, I try to maintain my integrity, but I feel like my integrity won't be maintained when I'm in this profession, because at the end of the day, I feel like it has broken me." And many of them felt like this. Some of them talked about sacrificing themselves for the sake of the patient, for the good of the patient. It was just about them going over and beyond, carrying out all these extraordinary practices just to ensure that they got the required outcome. But this was putting them at risk as well. Then we have the second pathway, which is the peer-supported survival pathway. Now, these ones experience values violation through a shared professional identity. They felt, they were not alone. They had some other interns that that shared similar experiences with them. And so it was possible for them to collectively and ongoingly reinterpret their practice. And in this way, they were able to share their moral emotions. So we see moral emotions being modulated in this path, for those that engage with this pathway. We see that relational, emotional knowledge support, particularly when they had or formed inchoate practice communities where they learned together, they taught each other, they watched YouTube videos together, they Googled together on how to tackle certain procedures, particularly when there was the absence of supervisory support. And so here we see the response outcome as being contrary to the traumatized departure. We see these ones being able to reconcile their experience, being able to tolerate systemic failure because they were doing it collectively. They were not doing it alone. Their emotions were hurt. They were good. They could buffer it with others as long as they prioritized their their professional network. And so we saw across the data, they talked about a ritual of venting, of talking to people. For instance, this quote says, you think your experience was bad until you hear the other person's story and you're like, wow, mine is not so bad actually. So she said, seeing another person going through the same thing and then having to talk about it with your peers, it really helps. And this way, these ones were able to survive the environment of even when they experience failure. The last pathway that we found from the data was pragmatic acceptance pathway. And these ones basically engaged or took on the general behavior that they saw existing workers carrying out. So they experienced values violation as fatalism. That is, whatever is going to happen in the system, it's not their fault, it's the system's fault, it's bound to happen, it's unavoidable, whatever happens, it's outside of the control of the doctor. And so we see moral emotions here being dampened, and these ones were able to succeeded in doing this, particularly by going on with observable behavioral scripts. That is, they just mimicked what they saw other people, their seniors, do. This way they were able to morally disassociate themselves, create that emotional distance, absolve themselves of any kind of responsibility, and even when they faced, or even so when they witnessed and when they partook in the systemic failure itself. So, but this kind of response reproduced systemic failure, of course, because they were carrying on doing what others were doing, which is basically reproducing those failed processes. And the way they were able to continue with this was by temporal bracketing. The internship was an internship that was compulsory, but just for 1 year. And they just felt, as long as I can do this for a year, I'll be fine. This quote, for instance, says, what I've seen most of us do is become hardened and numb. You just do your work and just pray that hopefully you finish internship. So it was about, this is going to end at some point. I just need to do what I need to do and get out of this place. So that's the pragmatic acceptance pathway. So these pathway responses helped professionals. We saw that throughout the data that this was what they leaned on to survive the systemic values validation. And this is just a very sketchy framework of that experience. We see the 3 pathway experiences. We see the role of moral emotions. In the case of traumatized departure, we see it is intense, and we see them going out of their way. We see how it's all about their selfhood and all about themselves. You see how they, go about doing the extraordinary interventions, but this can produce moral injury, and they need to escape from the systemic failure because there's only so much that one can take. In the peer-supported survival, we see moral emotions being shared. It's all about the collective, or it's the self in the collective, and this helped them to morally reconcile what they were experiencing and even tolerate systemic failure to a large extent. And then we see for the pragmatic acceptance, we see how self is disconnected from whatever is going on. There's a lot of detachment of emotions. We see some conforming to scripts, and that we label this as moral disassociation and reproduction of systemic failure. The main idea for my PhD at the time was to contribute to theory, and this kind of is a mid-range theory for sociology of professions because it provides a brief insight to how new professionals are socialized in the front lines in the face of systemic challenges. It also shows the role of moral emotions during this process of socialization. In my work, for instance, we found that moral emotions act as the motor that drives the traumatized departure. It is the glue that binds peer-supported survivors together, and it is the rust that can lead to pragmatic acceptance. And also, because there was the challenge of presenting my work theoretically so that there's no in a respectful way, this work kind of opens boundary conditions for Western explanations in this context. So that's the first study, and like I said, this was what my PhD was all about. But then this second study is what we're currently working on. For this second study, it's drawn from that particular work, and this is on moral distress, moral injury, and gray zones, an empirical study of new health professionals in Kenya. I'm just going to breeze through this one. This is the work we're doing on the currently working on with the Roots in the Roots program. This particular paper was submitted to Social Science and Medicine, and is currently under review, second review with Social Science and Medicine. Again, I would like to acknowledge my co-authors in this one. This one involves a larger data set because it involves medical doctors and nurses as well. So yeah, I'm acknowledging my co-authors. These are the co-authors. So just going in, again, I'm going to start with this quote for this particular study. And this quote says, the impotence this is made by a consultant, and he's basically referring to new doctors and nurses when they come face to face with the reality of practice. He says, the impotence, not being able to help patients who are in front of them, and coming face to face with the reality of, if I was in a well-equipped setting, I can save this person. But since I'm here, I'm going to lose this particular patient. And he says that moral injury becomes real. And that is what we're seeing in a lot of health contexts, not just this particular context that I studied. We're seeing a lot of moral distress and moral injury. Literature talks about these two concepts as being the invisible epidemic that is plaguing a lot of health systems across the globe. Moral distress initially was defined by Jameson as when no one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. But this definition has evolved over time, and it now involves when you don't even know the right thing to do, you can be distressed as a result of that. And then there's moral injury, which we saw during the COVID pandemic, quite a lot of that, which is the repeated fundamental violations of values and meaning, which can have adverse effects on psychological, social, functional, and existential aspect of one's life. In summary, moral injury can be described as the wounding of the soul or the wounding of the conscience. And like I said, it is becoming an invisible epidemic in many contexts around the world, in many health systems around the world. Now, we use the concept of gray zones to explain moral injury and moral distress. Just to give you a little bit about what gray zones mean. In early studies of gray zones talked about gray zones in the Nazi concentration camp. Levi refers to the experience that couples in the Nazi concentration camp faced. These couples were Jews, but they were forced to partake in immoral acts against their fellow Jews as a way to survive the brutal coercion. So in this case, we see that the line, he was describing gray zone as situation whereby the line between victim and perpetrator is blurred. And then in organization studies or management studies, we see Antaby describing gray zones as spaces in which both workers and supervisors engage in officially prohibited yet tolerated practices. So he went into an aeronautic organization, and he saw how workers were, crafting artifacts using organizations' materials, even though these artifacts were not for official or organizations' purposes, but they were, crafting these materials, and they were not being seen as a bad thing. Supervisors basically tolerated these. However, when these artifacts were, used for something else. Oh, sorry, I'm just hearing another. However, when these artifacts were used for something else, those who diverted these artifacts were labeled as transgressors, and they were punished accordingly. In the healthcare setting, we see some gray zone situations. For instance, a lot of literature on low resource constraint context has talked about gray zone situations, but they didn't use the concept itself. They described how, due to the contextual challenges, health systems in low resource settings engage in diluted practices or pluralistic norms. They've talked about liminal practices. They've talked about practical norms being used in practice. All these things are all these practices just show how are practices that are ill-defined, that are very ambiguous, and so we characterize them in this paper or in this study as gray zone practices and gray zone situations. Now, based on our previous study, we see that new professionals are bound to experience a disconnect between professional ideals and what happens on ground. And so we saw also that when they're exposed to violations, this can trigger moral distress or trigger moral injury. And we expect that this can happen also in gray zones. But now we sought to answer the research question: how do health professionals experience and navigate gray zones in resource constrained settings, and how does this relate to moral injury and moral distress? Again, it's a qualitative study. This time we drew on a larger set of data. We collected data from 146 semi-structured interviews. This study also involved focus group discussions. We had nurses, we had final year students, we had junior medical officers, we had senior consultants, and these ones were at some point they had done their internship, and it was really nice to have this broad data, because we felt the period we collected our data was during the winding down of the COVID pandemic, but having data from senior doctors and other doctors and nurses helped us to capture enduring features of the Kenyan health system, of the constraints in the system beyond the years of the pandemic. So it was not like, oh, it's just because this was during the pandemic. We felt that the data we had was able to give us a better picture of what happens even when there's no pandemic, and when there was no pandemic in the picture. And so the analysis for this one was very abductive. We were going from data to literature, trying to mix inductive study with deductive strategy in order to arrive at a theoretical explanation of the clinical finding. Again, we engaged with the GERM method just to make things more transparent, to show how we went from the first order code to the second order code and then to the theoretical construct. We identified gray zones by leaning on Sherman and Killenberg's paper on Beyond Burnout, Moral Suffering Among Health Care Workers in COVID. We felt that the elements that were listed in this paper created gray zones in that we identified in our data. We felt these elements, epistemic uncertainty, resource shortage, and institutional abandonment, we identified these in our data that brought about situations that the notion of right and wrong could not be well defined. And so that was how we identified gray zones during our analysis. So here we see in our findings, we identified epistemic uncertainty. New health workers felt they didn't know how to act. They couldn't apply their knowledge because there was that lack of supervision, and this brought about distress or injury, that sense of betrayal, sense of regret, helplessness. The resource shortage that they experienced also brought about some sense of, the loss of meaning, a conflict in their values. Am I doing the right thing? Am I caring too much? How come I'm not able to live out the altruistic values that I felt I was going to meet when I wanted to become a doctor or a nurse? So there was that regret, and that's a form of distress. And then with the institutional abandonment, we saw a lot in our data how these health workers were left alone, but then they were still held accountable for the patient's outcome. And so this brought about some form of confusion, helplessness, fatigue, frustration, just the sense that their moral purpose had been undermined and they had been duped really into this into working as in this health system. For instance, this quote says, "My rotation as an intern was terrible. I lost quite a number of patients. I was the only one available at the time. So being an inexperienced intern, not having supervisors available to bail me out during those surgeries, and then also taking criticism for those poor outcomes." This consultant said during his time, he felt it was terrible. And so so much of the data talks about how these ones felt their conscience had been wounded and showing signs of distress, showing signs of moral injury. And now we're going to look at how they navigated this distress and these conditions during internship. So the first way that we found that they've navigated this was through detachment. And detachment because they felt they needed to persevere. So whenever they encountered gray zone practices, many of these new doctors and nurses felt the need to engage in adaptive and protective strategies. And they did this through two means. The first was through emotional or moral indifference. And we saw this in the data where many doctors talked about feeling withdrawn or running away from, they use words like running away from the practice environment, disappearing from practice. One of them talked about how he was soft before, but then being in the system made him more hardened. Some of them talked about the lack of motivation to work, turning to hard drugs, but there was just this general need to numb the pain urgently in that space. And then the second way was through shifting morals. So many times the doctors entered the practice environment with a certain knowledge of the ideal of how things should be. But after a while, they became more comfortable with and even justifying transgressive practices. For instance, scoring. Many of them felt scoring was bad. Scoring just means taking money off the patient and the patient's relative instead of having them to pay through the official channels for the services. So they felt it was okay to score the patient because, you've not been paid by the government. Who else would you get money from? Of course, it's the patient. Many of them felt the need to justify these kind of transgressive practices. For instance, this quote says, "You're losing patients. There's no support for that. You're resuscitating on this bed and the next bed is calling you. You don't have enough manpower for anything." One of our consultants called it moral injury. She was like, "You guys are having too much moral injury." That just really took a toll on me. So I decided to take a break from clinical practice and do other things. But the need to take a break from clinical practice is further worsening the already shortage, the shortage in the healthcare workforce. And so we see that the more they engage with these adaptive protective strategies, the more they created conditions for moral distress and moral injury to thrive. And so the outcome of this was the normalization of unacceptable practices, frustrations. There was the blurred lines between who's the victim and who's the perpetrator. There was, that continuous sense of betrayal and thoughts of leaving the clinical practice. The second way they responded to gray zone situations was through repair reconciliation. And like I said, it's quite a link to my first work. So I'm just giving you for this one. And we saw that the repair reconciliation was engaged because they felt the need to ease their moral conscience. And so we saw that when they engaged in practices that were ill-defined, that they didn't know what to do, they saw themselves engaging in improvisation, learning a new kind of medicine, Some of them called it performing miracles, engaging in medical witchcraft, but ensuring that they had that creativity in to help patients or to achieve the desired outcome. So we saw many of them, engaging in workarounds, reusing consumables. For instance, this quote says, in the newborn unit, oxygen was a problem. We used to be very creative in oxygen sharing, using bottles and prunes, and it wasn't very nice. So although some of these practices were not, were risky for patients, they still felt at least we've done something. At least we've eased our conscience and we've done something for the, to save the life of the patient. Another way they engaged with gray zones or navigated the gray zone situation was through reflective peer connection. There was this sense of collective experience that they had. And so when there was the absence of institutional supervision, also guidance, they saw themselves coming together, engaging in confessional conversations. Oh, I killed the patient today. Oh, don't worry, you won't kill the patient again tomorrow. You'll be fine. Just trying to reinterpret their experiences, forgiving each other's transgressions, and providing that sense of soft accountability towards each other. For instance, this quote says, all the intent, this particular doctor had experienced a very bad situation where one of the babies he was tending to suddenly passed, and he was very distraught, and he said, all the interns in the department came to see me. They told me that the baby was actually critically ill, and I had done everything I could have done to my best, and that the case was beyond me. I should not blame myself. I think if all that hadn't happened, I probably would have completely collapsed. This sense of support, this sense of forgiving and reinterpreting the situation really helped them to ease their moral conscience, to repair what they felt was broken at the end of the day. And the outcome for this was reliance on professional colleagues. This helped them to strengthen their professional bond. However, particularly when they engaged with improvisation, there was a lot of compromise to professional standards. We also saw from our data that this increased the grievance against the health system and gave them a sense of heightened sense of institutional abandonment, because they felt nobody else has got our backs. We only have each other to depend on. All in all, we found out that repair and reconciliation helped them to rebuild a sense of purpose and agency. So it wasn't like they felt helpless anymore, or they felt that to a large extent, yes, they did feel helpless, but this kind of gave them a sense of purpose and agency despite the situation that they faced in that context. And so those are the two ways. Again, this is just contributing to literature to show that moral injury is not just in exceptional circumstances, but we see moral injury in places where gray zone situations are being negotiated. We see moral injury as not just the individual's problem, but rather it can be socially and structurally embedded in everyday practice. We also see our work contributing to the literature on professional socialization and resocialization, showing how new professionals are, resocialized into a new or emergent moral order by their collective negotiation and redefinition of moral expectations in gray zone spaces. This way, they were able to rebuild understanding of care, foster learning when there was no institutional guidance, and create a new sense of purpose and agency. They did this through improvisation. Even their decision to detach is a way of exercising agency. Their decision to lean on each other through reflexive peer connection was also a way that they exercised their agency in the new moral space. And then lastly, we contribute to literature on moral distress and injury in low resource setting. And we see that there's a lot of structural injustice in low resource settings, and that kind of makes gray zone a very permanent feature of daily work, which means that moral injury and moral distress is a permanent feature of this kind of, in this kind of context as well. And so challenges not just lies in personal failure, but we need to understand that there are systemic conditions that makes compromise an inevitable and unavoidable part of care. in this situation, and this can trigger distress and injury. And more importantly, we see that with the recent cuts in resources, a lot of health systems are sharing this experience, and so we see that moral distress and injury is fast becoming a very shared experience globally. And we have practical implications. First of all, we need researchers to recognize that there are gray zone situations, and we don't need to, reduce moral distress and moral injury to discrete black and white categories like we did during the COVID pandemic, but to look at within gray zone situations how this can emerge and how this can be addressed. Also, we see from our data that many new professionals face that reality shock of because many times they were not exposed to resource limited settings, and they didn't anticipate the ethical challenges. So we feel that this is necessary for training. We see senior health professionals playing a critical role in modeling the right behavior, in creating psychologically safe space for learning. We also see organizations playing a huge role in creating safe spaces for peer support groups, for ethical debriefing sessions, and finding ways to process these tensions collectively. Lastly, we see efforts that policy should incorporate, ensuring that the structural drivers of moral distress and moral injury are properly addressed. Which brings me to the current program that I'm working on under Professor Sassy, being sponsored by the NIHR. It's called the ROOTS program. ROOTS stands for Rethinking Organizational Opportunities to Tackle Moral Distress. And this is about focused on tackling moral distress on the front lines among healthcare workers and health research staff. It's inspired by frontline needs and possibilities. It's a participatory action research where we're going to be where we engage with training and building case studies for frontline workers, and generally sharing what we've learned and with each other and learning from each other and as we go on. And these are the aims of the ROOTS program. It's quite an interesting program so far. And it's about amplifying the voices of those on the front lines, showing their experiences, and being able to capture data that literature that have not been captured among frontline workers, and building a rich understanding of the concept of moral distress and related concepts. It's about developing context-sensitive assessment tools. Right now we're working on the tools development for measuring moral distress and moral injury, and this can be accessible and applicable in low resource settings. Also, we aim to identify interventions through co-design and formulative evaluations. We also have been working on providing guidance, manuals, agreements, and expectations across various levels. For instance, the recent manual that we produce on ethics in practice on how to support researchers when they navigate everyday ethical challenges through ethics debrief sessions. It's quite an interesting one. If you would like to read that, can you reach out to us? And in general, the ROOTS program aims to improve well-being of frontline healthcare staff and equity in research practice. And we aim to focus on the individual level, the team level, and the organization level. So we're working with partners in India, Bangladesh, and so many other African countries. If you're interested, and you're in Morocco, we would like to partner with you. If this study resonates with anything that you're doing, kindly reach out to me, and I'll be happy to talk to you more about ROOTS program. So that's it from me. Thank you very much. I'm going to pass over to Catherine right now.